Hello, thanks very much for having me. I'm Hugh Huddy. I work at the Royal National Institute of Blind People in London, and I've been working alongside and with, and well, I've got some grey hairs now, working with NHS England on the Accessible Information Standard. And I just wanted to talk for 10 minutes or so on what you can do about it, how it affects you, what's the most effective ways of you meeting people like me, information needs. I think visual impairment, just to start off with, is one of these things which, as we've heard today, when as Liz said this morning, you're kind of given this definition of going blind. I think what happens to you after that is a sort of pretty well a mystery to society in general, and then the only sort of, if you're thinking now, well, who are the most well-known blind people that you know? You probably think of David Blunkett if you're a Labour supporter. And you might think of Stevie Wonder, and there are a few other people who are sort of well-known, completely blind people. The vast majority of blind and partially sighted people in this country are older people. It's concentrated in older age. But there are something just short of 100,000 people who are of working age who have either visual impairment or severe visual impairment, and there are these different definitions. When it comes to the Accessible Information Standard and what you need to do about it, I can't see you, so can you shout, or not too loudly, how many people have actually heard of the NHS Accessible Information Standard? Have you come across it? No. I wish I had NHS England in the room now. I've been telling them this for ages. There are very few clinicians and GPs have actually heard of it. Now, they've done extensive promotion of this standard, and I won't start my stand-up routine about how we have differences of how communication actually works, but I'm kind of not that surprised that you haven't heard about it. What I would hope more is that your practice managers have heard about it. So if you can go back and check that your practice managers have heard of the Accessible Information Standard, and even better, are taking the first few steps to implement it, then great. And what I'm going to do in a few minutes now is just give you some tips on how to sound like you know what you're talking about. Otherwise you won't be very authoritative. So I'm going to empower you to do that. So there's three things I'm going to just talk to you about now. One is what the standard is. Or two is how many people in your practice might you need to make adjustments for. So how many people who, when you chuck them a piece of paper, a leaflet, bit of information, can they just really not read that? Really not use it. They'll have to hand it to somebody else, they'll get lost on the way home and not do the job that it should be doing, especially if it's a treatment guide or something, or a set of instructions that the blind person once handed me which said, do not take this with grapefruit juice. What is this? So, oh, it's actually a warning about your medication. Now these are the sorts of things that happen. I won't go into the sort of downsides of what happens if you miss information. But when I first started working in the campaigns team at RNIB, I was asked to do a big piece of research with Dr. Foster on the experiences of blind and partially sighted people with NHS information. They found that 95% of blind and partially sighted people didn't get any information from the NHS in a format they could personally read. It also found that 97% had never asked for it. And I think that was the most interesting point, because you probably won't get to know. So what the Accessible Information Standard says, and it's part of the Health and Social Care Act, so it's a legal obligation. It's in addition to the Equality Act 27, which you may not have heard of either. But I don't mind, you're not here to be tested on what you know about equality legislation, that's my job. But equality legislation was put in place many years ago to try and make sure that disabled people have equal access to things. What the Accessible Information Standard does is it reinforces that. It gives it this thing called statutory underpinning, which is not a building term, but is in actual fact a way of the government recognising that in the NHS accessibility wasn't working and the Equality Act wasn't really working. So they gave this extra underpinning, and that's what NHS England did by producing the standard. It requires that all providers of NHS services identify someone's access needs. So just in a quick tip on how you do that, someone walks into a surgery with a blind scope. perhaps not more complicated, or a guide dog. Or they appear not to be able to read what you're handing them. There's another way of doing it as well. You can ask them if they can read it. It's as simple as this. It's not complicated. It just might not be the first thing you think of doing, because we're very sort of practiced in handing people information in print and not really thinking about what happens to it afterwards. We just assume the person will, that bit of paper should just do the job. A bit frequently done. The second thing is to capture that requirement on your computer system. I don't know how many people use EMIS in this part of the country, but in London, EMIS is used almost completely across the whole of the London area. And there are some read codes on there for capturing someone's access needs on there. There are also some other techniques you can use on EMIS systems, and TPP are also implementing this. It's got these SNOMED touch read codes for large print, braille, audio, email, need an audio alert, need a visual alert. These are the sorts of read codes which hopefully your practice managers can have a lot of fun with and implement across your practice so that you get the right flags and you can know what people need. The third thing is record it, so put it on the patient record. The fourth thing is share it. That means when you're making a referral, you may do this already. You may say this patient can't read print, please make sure you give them emails or large print. You may do that already, but the standard sort of formalises it. And the fifth thing is act on it, which is rather hard. Act on it. It's actually might not be very easy for you at the moment. If someone said, I need that in the 18 point and you're handing them a treatment guide, what would you do? And do you have a system for doing it? Is anyone willing to just say if they have a system for someone said, can you do me that in 18 point because I can't read it? Have you done that before? No. I will now get on to the prevalence of sight loss and numbers of people on your patient list. So what we did, we worked with Dr. Ralph Sullivan at RCGP, who's the clinical lead for Patient Online. So I'm also chair of the NHS England group on Patient Online. So we took a patient index of 12,000 people and we applied the prevalence of registrable sight loss against that. It came out with about 600 people won't be able to read 12 point. That's a practice index of 12,000. It came up with about 72 to 80 would be registered blind or partially sighted. That means they will need large print 18 point or above. Information that they can read on their digital device, like I'm using on my laptop. I'm actually listening to my notes through my earpiece, read out to me. So I'm sort of listening. I can do that on my phone as well. So I get information through my digital device. I developed sight loss too late to learn Braille. And anyway, we've got computers nowadays. Who wants to learn Braille when you can have an iPhone? It's more exciting, but don't tell that to the old school people of Braille. So, then we worked out about sort of 35 would need email communication. We just have no other way of communicating because they've got either deaf blindness and they use particular types of access technology. We worked out about 3 to 5 out of the patient index of 12,000 would need Braille. So you can see the numbers of people actually needing Braille, which is often a big worry to people, is very low. So your practice manager would need to have a mechanism for doing Braille, but the number of times you'd have to do it would probably be quite low, or would be very low. And the types of information you'd give in Braille would be something that that patient really did need to read for themselves. Those patients may also be able to access information through a digital device. So if you ask them, it's cheaper and quicker for us to give you this in digital, but we could do Braille if you absolutely have to have it. If the person's able to use digital, then they do that and mark it on the record. Okay, I won't go into, because there's not very much time, so I want to hand over to Steve and Josh in a minute. The third area is sort of strategic tips for what you can do. I'll just arrow down my thing so I wrote these out during the day. I was listening to, spent the day listening to all, well, most of you were listening, but I listened to the presenters and the questions, and I thought, well, okay, these are quite important points. The first thing I was going to say is, for strategic tips, capturing access needs is not the same thing as capturing disability status. So if someone says there's a data protection issue or a patient confidentiality issue here, when you're capturing the fact that somebody needs large print and you're sharing it with somebody else, that's not a disability status. It's not personal information about a patient's medical condition. it's simply a reading preference. So that might reassure some people that, and just clarify the difference. This standard is about access needs. It's not about capturing disability status. So if someone said they need email communication for a disability adjustment, then that's not capturing their disability status or medical condition. So, last bit. I've got some examples here of, Liz mentioned one this morning, and that is, do you have a register of patients with visual impairment? I picked up from the group that nobody has. What Ralph's done with his practice in Yorkshire is he's worked out some simple search techniques to search his EMIS patient list and the patient records. And using a 3-pass system, he's pretty confident that within about 15 minutes, less than that, I think, he got a list of everyone who's likely to have visual impairment in his practice just by searching the patient record. He used some different techniques for doing it. For example, searching for CVI, which is severe visual impairment on the record, and problem seeing, a few other keywords which you searched on. So you can't just do it with one search, you'd have to do a 3-pass. Now, your registration, when new patients register, do you capture their access needs in that register? So do you say, can you read standard print? Yes, no. If no, what alternate format could we provide you with to ensure you can read information yourself? There's an example on NHS England's website of a demonstration patient registration form which shows how you can do that in your form. So if you've not done that, it'd be really a good way of meeting the new standard to adjust your registration forms.
It doesn't have, it doesn't explicitly ask you whether you have a visual impairment, but it does ask you to describe if you have a disability. So
you're right.
Free text you can write.
Yeah, that would help you, I guess, in searching your database for people with human. But you could modify the form and actually just capture the actual format needs, and then that would.
So what would you suggest we say? Do you have a visual impairment?
I'd rather give you the example of NHS England's, because they've thought it through with us. Yeah, they've thought it through. There's a few things I wouldn't take too long to explain now, but there's an example form anyway, which we think is good. There's read codes which are on all pushed through GP SOC last year, so all the read codes are already available to you. I can't tell you how to go and find them. You'll know more than me about that. But the read codes are in there for marking all these accessible format needs. And the last few things I was going to say here, I've run out of things to say. I'm just going to leave it there. Then I think I've probably deleted a few of the things I wanted to say because I knew I was running out of time. So that's the standard. Have you got any quick questions that you would like to ask me? That was a good one, by the way. What do I recommend we say on the form? I think what it says on the NHS England form is it doesn't ask you if you're visually impaired. It asks you what access needs you need from this list to tick all that apply. So I think it actually doesn't say, tell us what's wrong with you or what your disability is. It just says, what do we need to put on your record, sort of thing. And it links through to the read codes so that you get a read across.
So that's a form, isn't it, that you have to read?
Yeah, well, the form's available in large print, or can be. If there's a mechanism for doing that, there's a mechanism for emailing it. Some of these things will have to be worked out. I mean, many of these things have not been properly worked out, and even NHS England don't know how to do them. What we want to do is work with any GP practice trying to implement this, because at RNIB our interest is to try and help you make sure you do it so it works for the people we represent, but works for your patients too. And if there's things that NHS England need to do, then we're independent and we can lean on them to get them to do it.
So being contacted by email, do you get your email in an audible form?
My laptop just reads out the email, and it's the same with my phone. So as soon as a text message or an email lands on my phone, just I just use an ordinary Motorola phone, and you just switch to accessibility mode on. It's all built in these days. It's too much for me to explain now how I use a mobile phone, but I can use most features on a mobile phone apart from playing games, which my son does instead. I grab my phone to go off to work and it's running out of batteries. Because he's snuck on the phone and he's always worked out my password, so I've given up trying to get on that way. But he's only 7 as well. But yeah, he also knows how to turn my accessibility features on and off as well whenever he wants. But he's so good, he leaves the accessibility back on when he's finished. And actually I thought he was being really nice, and then I said, why did you do it? And he said, oh, it's so you don't notice. Didn't realise. Also, I had a really there any other technical questions about accessibility?
Any other questions? I'm looking. No.
What I've got is I've got a GP FAQ leaflet which we wrote with Ralph, and I can email it to you.
Yep.
And if you have if I'm able to send it via you though, if you have an email list,
Yep.
then we can email that out. I didn't want to bring bits of paper today because I don't like paper generally, I guess it's not either. But I'd be happy to email that to you, and also there's a resources page on NHS England. But I'm most interested actually in, this isn't just reading some guides or reading some good practice, this is actually getting on and just starting a few steps, taking a few of these steps to modify the way you capture and use information about people's needs. And I would like to work with anybody who's trying to implement this. There's a practice in Birmingham who's already made some really, the practice manager is an ex-computer programmer, and she's just implemented all of this because she's so good at it. But I know that's not the case for all practice managers, so I'll be happy to be linked up with anybody to be a facilitator and help troubleshoot things. Thanks very much.
One more question.
If information is sent to you in email form, does it have to be in the body of the email, or are there certain formats in which an attachment could also...
Yeah, very good, very, very good question. If it's just short information, you can just type it into the email message body. You can even just if you just want to give some information, say from NHS Choices or something, you just want to give some people, a patient, a few key things about their condition, you could just copy and paste it into an email message and send that. But if you wanted to say attach a PDF, then the best thing would just to check with the patient.
But it
is
is
it okay
possible.
does email? Yeah.
In sort of PDF form
Yeah,
or something like
yeah.
that.
Yeah, I mean I do use PDFs. Some of them are a bit squishy with my speech converter.
Yeah.
But if they do, then I just send an email back saying, oh, actually, could you just send me the text? I've only done it once, and my ophthalmologist from Moorfields, he always emails me things now. But he has said until very recently, I'm not really sure whether I'm allowed to email you or not. And I said, well, the beauty of that is, Prof. Webster, I'll just send you an email to give you permission. And he said, thank you, it's a done deal. So we do that, and that's been fine. And it's always worked. We get around Caldecott and everything that way. So and he also knows I work on this with NHS England, so he's probably knows I'm reasonably safe. I'm not going to dock him in on anything if he's done anything wrong. But the NHS England have actually got a specific guidance note on this to NHS professionals, which explains that email is permitted as a reasonable adjustment under the Equality Act and the NHS Information Standard, but you do need to have a permissions mechanism, so you do need to explain to the patient. When the first email I should have said, I'm seeking your permission to send you this information by email. Email may not be secure, and please give me written permission. And then when you get the reply that says, you've had your date of birth, this is the address I gave you at the surgery, and I am giving you permission, then the Caldecott Guardian said that they were happy with that. So there's an NHS England guidance now on it too.